We often picture our blood as um, this flawless public transit system. Like everybody's on the right train, moving smoothly, delivering oxygen and nutrients to the exact right destinations.
Right, and under normal circumstances, that transit system is perfectly regulated. The infrastructure is built for those specific passengers, you know?
Yeah, as long as they stay on the tracks, the whole organism thrives. It's the ultimate biological good guy.
Exactly. But pull that same blood out of a vein, spin it in a centrifuge, and inject it into a damaged knee joint or, say, a torn Achilles.
Suddenly, you have totally derailed that train, right in the middle of this delicate, closed ecosystem.
Yeah, and the casualties of that derailment are the exact reason why a seemingly miraculous treatment can just suddenly cause intense, agonizing pain.
Which is wild.
Yeah.
So welcome to the deep dive. Today we are unpacking the underlying science of platelet-rich plasma therapy, or PRP for short.
And we are skipping the basic overview today to focus directly on a highly requested mystery.
Right, because if you've ever had a PRP injection, or you know someone who has, you might have heard two completely different stories. One person walks out feeling fine, experiencing rapid healing.
But then another person experiences this severe, localized soreness and swelling, like it leaves them completely unable to bear weight for days.
Yeah, and solving that mystery requires looking at a stack of cutting-edge clinical research. We're pulling insights from Adam Loicono's comprehensive guides to orthobiologics. We're diving into medical reviews on PRP dosing and cellular composition.
Not to mention some incredibly detailed molecular studies on hemolysis, ferroptosis, and microvascular function. It gets pretty deep.
It really does. Because the core of this pain mystery actually centers on a microscopic contaminant, something that is never, ever supposed to make it into the final PRP syringe.
Right, the erythrocyte, better known as the red blood cell.
And what unfolds when these specific cells are forcefully relocated to the wrong neighborhood is a bizarre biological saga. I mean, we're talking cellular scavenging, chemical theft, and active warfare inside your joints.
To understand how this goes so wrong, we first have to look at the mechanical process of separating the blood.
Right, because the foundational promise of PRP is that a clinician takes a small sample of your blood, processes it, and isolates the plasma that's densely packed with platelets.
Exactly. Platelets act as your body's first responders. When they're introduced to an arthritic joint or a stubborn, non-healing tendon, they release growth factors.
And those growth factors are basically a biological flare gun, right?
Yeah, that's a great way to put it. They recruit stem cells, monocytes, and other reparative cells to the injury site to, modulate inflammation and physically rebuild damaged tissue.
So you are essentially taking the innate healing power you already possess, concentrating it into a superdose, and deploying it exactly where it's needed.
That's the theory. But diving into Adam Loicono's orthobiologics guides, a glaring issue becomes really obvious. The regenerative medicine space is a bit of a wild west when it comes to standardization.
Yeah, not all PRP is created equal, and that's largely because of the hardware used to create it.
Right. The clinical goal of the centrifuge process is to isolate those lightweight platelets and leave the heavy red blood cells trapped at the bottom of the tube.
But the problem is that different commercial centrifuge systems devices you'll commonly see in clinics, like the SmartPrep or the Genesis CS, they operate on entirely different parameters.
Exactly. They have different spin times, different gravitational forces, and totally different optical sensors for drawing off the plasma.
And in many of these systems, the filtration is highly inefficient, isn't it?
It is. The buffy coat, which is the layer containing the platelets, it gets muddy. So instead of yielding a pure, translucent golden liquid that clinicians call yellow PRP, they produce red PRP.
Meaning it is heavily contaminated with red blood cells that just got sucked up in the extraction process.
Precisely.
Okay, but let me push back on this for a second. Why is this categorized as a contamination? I mean, we are talking about my own blood.
Right.
My entire body is flooded with red blood cells, and they are essential for my survival. So why does relocating my own cells into my own knee or elbow suddenly trigger a massive crisis?
That's the perfect question. The answer comes down to the environment. Red blood cells are structural marvels, sure, but they are highly specialized for the bloodstream.
Right, they're meant to be in the veins.
Exactly. They're smooth, they're flexible, and they're designed to flow continuously in a fluid dynamic environment.
So taking them out of that fluid environment is the issue.
Yeah. The synovial fluid inside a joint capsule, or the tight, densely packed collagen fibers of a tendon that represents a harsh alien landscape for them.
Oh, wow. So when you forcefully inject red blood cells into these closed ecosystems, they just can't survive.
They can't. They undergo a rapid, violent breakdown process.
They essentially panic and self-destruct because the osmotic pressure in the environment are entirely wrong.
That destruction is clinically referred to as hemolysis. The red blood cells degrade and lysize, meaning they literally burst open.
And when they rupture, they just spill their internal contents into the joint space.
Yeah, and the research highlights a staggering metric here. Red blood cells are packed with chemokines and cytokines, which are inflammatory signaling proteins.
Wait, they have inflammatory proteins inside them?
Oh, yeah, at concentrations 12 times higher than what is found in normal cell-free blood plasma.
12 times higher. That basically transforms those cells from oxygen carriers into little inflammatory bombs just waiting to detonate in the joint.
100%. And the local tissue reacts immediately to that detonation. The joint space is lined with specialized synovial cells.
The type A macrophage lining cells, right?
Yes. You can think of these as the native janitors of the joint. Their biological mandate is to keep the synovial fluid pristine and free of debris.
So when they detect this massive influx of ruptured red blood cells, they go into overdrive.
Exactly. They initiate a process called erythrophagocytosis, which means they attempt to physically engulf and consume the rogue red blood cells to clear the area.
It paints a totally chaotic picture. It's like a bouncer at a club trying to swallow a rowdy patron whole just to get him out of the building.
That's a vivid way to put it, yeah.
But the patron is so volatile that he bursts open from the inside while the bouncer is still trying to wrangle him out the door.
That analogy captures the localized trauma perfectly, actually, because when the red blood cell ruptures during that cleanup process, it releases its core components directly into the delicate synovial tissue.
We're talking hemoglobin, hemin, and iron, right?
Yes, and iron, when situated outside of a contained, safe biological structure, is highly toxic to human tissue.
Right, because the ferric iron undergoes a chemical conversion into toxic free radicals, specifically reactive oxygen species, or ROS.
Exactly. And we hear about free radicals in skincare and nutrition all the time, but in a joint space, this iron deposition triggers a condition called hemocytosis.
And hemocytosis directly stimulates the local immune cells to release heavy-hitting pro-inflammatory cytokines, things like interleukin-1 and TNF-alpha.
Right, and these are not just generic markers of mild swelling. They act as chemical sledgehammers. They actively dismantle the extracellular matrix of the joint.
Which leads to hyperplasia, where the joint lining panics, starts mutating, and multiplies abnormally.
Yeah, it thickens and scars the tissue, and ultimately that causes accelerated cartilage degradation.
The biological cascade is just brutal. The native joint macrophages try to eat the invading red blood cells, the cells explode, toxic iron saturates the joint, and the tissue responds by mutating and eating its own cartilage.
It is a complete disaster for joint health.
But looking at the timeline of patient experiences, this iron-driven cartilage degradation feels like a, slow-moving long-term problem.
It is.
So does this iron toxicity alone explain the severe, acute, I can't walk on my leg pain that hits patients within just hours of a red PRP injection?
Actually, no. Iron toxicity accounts for the swelling and the long-term structural damage.
Okay, so what causes the immediate pain?
To understand that blinding pain, the studies point to a secondary, far more aggressive mechanism involving the vascular system. We have to look at the behavior of nitric oxide.
Nitric oxide, NO, which usually plays the hero in vascular biology, right?
Usually, yes. It is produced by the endothelium, which is the inner lining of the blood vessels.
And its primary function is to act as a potent vasodilator. It signals the smooth muscle cells wrapped around your blood vessels to relax.
Exactly, keeping the pathways wide open for optimal blood flow. It actively downregulates pain signals and prevents localized inflammation.
Okay, so where does it go wrong with PRP?
While hemoglobin, the protein responsible for carrying oxygen, it has an incredibly high affinity for nitric oxide. It naturally wants to bind to it.
But in a healthy bloodstream, hemoglobin is securely encased within the membrane of the red blood cell.
Right. That membrane acts as a diffusional barrier. The hemoglobin is kept safely in the center of the bloodstream, physically separated from the walls of the blood vessels where the nitric oxide is being produced.
So the hemoglobin is essentially bound in a biological straitjacket, allowing the nitric oxide to do its job without interference.
That's right. But the moment that red PRP is injected into a joint and hemolysis occurs, that straitjacket is just removed.
The red blood cells burst.
Yes, leaving us with what the literature calls cell-free hemoglobin. This is naked hemoglobin floating freely in the tissue and the vascular spaces with no membrane to contain it.
And without the membrane, it just goes after the nitric oxide.
Oh, absolutely.
Mm.
The clinical data reveals a startling consequence here. This cell-free hemoglobin destroys localized nitric oxide at a rate 1,000 times faster than normal contained hemoglobin.
1,000 times faster. Wait, so it rapidly and aggressively converts the nitric oxide into nitrate and methemoglobin.
Exactly.
So the rogue hemoglobin acts like a microscopic vacuum. It instantly sucks up the very molecule that keeps the tissue relaxed and oxygenated.
And removing nitric oxide from that environment has an immediate, violent effect. Without NO to signal relaxation, the smooth muscle surrounding the local blood vessels just uncontrollably contract.
Wow. So this is severe microvascular dysfunction.
Yes. The blood vessels in the injected area clamp down so tightly that they choke off their own blood supply.
And this localized strangulation snulls the surrounding tissue of oxygen, inducing a state of sudden ischemia.
Precisely.
Well, that perfectly explains the acute pain response.
Yeah.
I mean, ischemic pain is notoriously agonizing. It's the same mechanism that makes a severe muscle cramp or a heart attack so painful.
Right, the tissue is literally suffocating.
So you aren't just feeling the prick of a needle. The entire vascular network in your knee or tendon is having a localized spasm because the cell-free hemoglobin stole the chemical key that keeps the vessels open.
It creates a localized vascular crisis entirely triggered by microscopic contamination. The physical trauma of the needle is totally negligible compared to the hypoxic environment created by the scavenging hemoglobin.
Okay, but if the red blood cell contamination causes toxic iron damage that degrades the cartilage and simultaneously chokes the blood vessels to cause ischemic pain, what happens to the actual platelets?
That's the real tragedy here.
Like, does this hostile environment neutralize the regenerative purpose of the PRP treatment itself?
It fundamentally sabotages the healing process. The research details a biological phenomenon known as erythrocyte.
Erythrocyte. That's the red blood cell equivalent of apoptosis, right? Programmed cell death.
Exactly. As these misplaced red blood cells begin to die off in the joint space, they actively secrete a specific protein called macrophage migration inhibitory factor, or MIF.
Hold on. If they secrete a macrophage migration inhibitory factor, doesn't that directly contradict the goal of the treatment?
It really does.
I mean, the entire point of injecting the concentrated platelets was to summon macrophages, monocytes, and stem cells to repair the tissue. Why would a dying blood cell evolve to secrete a chemical that blocks a rescue team? That seems like a massive evolutionary flaw.
Well, in the context of the bloodstream, it is actually a brilliant evolutionary adaptation.
Really? How so?
Think about it. Your body turns over millions of aging red blood cells every single day. If every dying red blood cell triggered a massive macrophage response, you would be in a constant state of systemic, catastrophic inflammation.
Oh, I see. So the dying cells release MIF in the bloodstream to signal the immune system to ignore them.
Right. It's a chemical way of saying, nothing to see here, just routine maintenance.
But when you concentrate millions of these cells and dump them into a closed joint capsule, that subtle whisper becomes a deafening alarm.
Exactly. It creates a biological roadblock, chemically instructing the exact stem cells and regenerative macrophages you paid to summon to stay far away from the injury site.
It is a profound physiological miscommunication. You endure the toxic iron destroying your cartilage, you suffer through the suffocating ischemic pain of your blood vessels clamping down, and at the end of it, the regenerative cells are blocked from even doing their job.
And to compound that miscommunication, we have to factor in basic chemistry.
Oh, right. The acidity of the injection.
Yeah. The pH of the injection itself plays a massive role in the patient's pain experience. The normal physiologic pH range of human tissue hovers really tightly between 7.35 and 7.45.
But the studies analyzing the output of various commercial centrifuge systems show that many produce a highly acidic PRP.
Right, with pH levels falling anywhere from 6.95 to 7.32.
Which is way outside the normal range. Why are these systems producing such an acidic fluid in the first place?
It traces back to the anticoagulants used during the blood draw. to prevent the blood from clotting while it sits in the centrifuge tube. Clinics use solutions like acid citrate dextrose or ACDA.
And as the name implies, it is highly acidic.
Very. If a commercial system is inefficient at filtering, or if it lacks a buffering mechanism to neutralize that citrate after separation, the resulting plasma retains that harsh acidity.
Wow, so if you were scheduled for a PRP injection or you're listening to this trying to figure out why your last treatment left you in agony for a week, this combination of factors is basically the smoking gun.
It really is.
You have an already inflamed, damaged joint. You inject cell-free hemoglobin that strips the nitric oxide, causing the tissue to suffocate and cramp.
Yeah.
And simultaneously, you are bathing those suffocating oxygen-starved tissues in an acidic fluid. I mean, injecting pure acid into an ischemic environment will universally trigger every pain receptor in the localized area.
The clinical application here is just paramount. Standardization remains the biggest hurdle in regenerative medicine today. A remarkably high platelet count is biologically useless if those platelets are swimming in an acidic bath of toxic, NO-scavenging red blood cells.
This highlights exactly why you cannot simply walk into a clinic, ask for PRP, and assume all preparations are identical.
You really have to advocate for yourself. Ask your clinician specific questions about their hardware and their protocols.
Right, and the optimal targets highlighted in the literature suggest aiming for a high platelet dose over 3.5 billion platelets per injection.
Working toward a cumulative dose of 10 to 12 billion across a treatment plan. But crucially, you need a system that vigorously and efficiently filters out red blood cells.
You are looking for pure yellow PRP, completely avoiding the red.
Patient advocacy is critical here. Understanding the difference between a system that relies on, say, crude gravity separation versus one with precise optical sensors that can literally be the difference between rapid tissue regeneration and a week of debilitating joint pain.
Absolutely. Let's map out this entire biological cascade one final time to cement the mechanics.
Good idea.
So, you receive a PRP injection that is contaminated with red blood cells. Because they are trapped in a joint capsule rather than flowing in a vein, they undergo hemolysis and burst open.
Right.
They release iron, which converts into toxic free radicals that actively degrade your cartilage. Simultaneously, they release cell-free hemoglobin, which executes a massive nitric oxide heist, scavenging the NO 1,000 times faster than normal.
Which triggers the severe microvascular dysfunction.
Exactly. Choking your blood vessels, starving the tissue of oxygen, and causing acute ischemic pain. As the cells die off, they undergo erythrocyte, releasing a factor that physically blocks your stem cells from arriving, entirely sabotaging the healing process.
And to finalize the trauma, the poorly filtered mixture brings an acidic anticoagulant along with it, burning the already suffocating tissue.
It perfectly illustrates how an intricate biological system can just spiral into chaos when just one variable, the location of a specific cell, is altered.
It is staggering how a microscopic contaminant can trigger such a devastating chain reaction.
It really is. We know the current solution is better filtration and demanding yellow PRP. But looking at the bleeding edge of the research on hemolysis and vascular function, what is a final provocative thought or potential future treatment we can walk away with?
Well, the research on mitigating hemolysis offers a fascinating glimpse into the future of clinical orthobiologics.
What are they looking at?
We have seen in extreme clinical cases of systemic hemolysis that researchers can administer inhaled nitric oxide gas to successfully neutralize cell-free hemoglobin.
Oh, wow. So the NO rapidly converts the toxic hemoglobin into methemoglobin.
Exactly, entirely stopping the scavenging process and instantly reversing the painful vasoconstriction.
If they can neutralize it systemically, the local applications could be totally game-changing.
It raises a brilliant clinical question. If a patient is receiving a PRP injection that might have slight RBC contamination, could a clinician simultaneously administer a localized targeted nitric oxide donor?
Or, as simpler studies suggest, could they routinely buffer the acidic PRP with a precise bicarbonate solution immediately prior to injection?
Yes. Implementing these incredibly simple, cost-effective biochemical safeguards could entirely bypass the vascular choking, neutralize the acid, and unlock the immediate, flawless healing potential of the plasma without the risk of an agonizing side effect.
Imagine turning off that chemical warfare before the first shot is even fired. Just adding a buffer and a chemical decoy so the blood remains the ultimate healer, rather than mutating into the intruder.
It's an exciting frontier.
It really is. Thank you for joining us on this deep dive into the microscopic battleground of your own biology. Next time you think about the cells flowing through your veins, remember, their behavior is entirely dictated by their zip code. Keep questioning the science behind your treatments, keep learning, and we'll see you on the next deep dive.